Elizabeth Ballou, and when I completed this case, I was in my last year of residency at Northwell Health, North Shore LIJ. The case I'll be presenting is breast nodular fasciitis. In our case, it was a 54-year-old female who was seen for screening mammography. She had no personal or family history of cancer. She had a history of benign bilateral axillary lymph node surgical removal. These are images of the right breast from the patient's mammography. On the left is a CC view, on the right is an MLO view. The yellow circle demarcates an irregular spiculated mass in the inferior central breast. These are images from the patient's follow-up targeted ultrasound of the breast mass noted on mammography. The left image is a transverse grayscale ultrasound image. The middle image is a sagittal grayscale ultrasound image, and the right image is an oblique color ultrasound image. All of the images show an irregular hypoechoic right breast mass at 6 o'clock 2 cm from nipple corresponding to the mammographic finding. The color image on the right shows vascularity within the mass. The patient underwent ultrasound-guided biopsy of the mass. The left image shows the biopsy needle adjacent to the mass in pre-fire position. The middle image shows the biopsy needle trough within the mass. And the right image is a post-fire image. This is the patient's pre-surgical breast MRI. The left image is a 3D maximum intensity projection image of the breast, and the right image is an axial contrast-enhanced subtraction MR sequence of the breast. Both of these images show an enhancing breast mass within the right breast. The mass had a type 1 kinetic pattern of progressive enhancement. The middle image is an axial T1 weighted image of the breast, showing a low signal intensity right breast mass with susceptibility artifact due to the biopsy marker. The diagnosis in this case was nodular fasciitis, which can appear similar to breast cancer on ultrasound and is often a mass with irregular margins. Definitive diagnosis is achieved via biopsy and histopathologic analysis. Nodular fasciitis does not result in clinical symptoms such as discharge from the breast, unlike malignancies. Nodular fasciitis typically shows benign patterns of kinetics on MRI, unlike malignant entities. Despite often rapid growth and a typically palpable mass, nodular fasciitis is often self-limited clinically and recurrence is rare. The top differential diagnosis for nodular fasciitis is primary breast cancer. Invasive ductal carcinoma and invasive lobular carcinoma are much more common than nodular fasciitis of the breast and can also present as a rapidly growing hypoechoic irregular mass. Due to the overlap in imaging appearance, biopsy is necessary to obtain definitive tissue diagnosis and to exclude the possibility of primary breast cancer. These are our take-home messages. Nodular fasciitis is a rare benign disease which occurs in the setting of fibroblastic and myofibroblastic cell proliferation within the soft tissues of the breast. This process has been described more typically within the soft tissues of the trunk and extremities. It remains important to distinguish this uncommon benign lesion from breast cancer. Ultrasound, mammography, and MRI have all been used to aid in diagnosis of nodular fasciitis non-invasively. However, biopsy is typically needed to clinch the diagnosis. Nodular fasciitis portends no malignant potential in the breast or elsewhere in the body and therefore carries an excellent prognosis. Thank you for your time and attention.